So my today's topic is interpreting urodynamics in pediatric neurogenic bladder patients. I'm going to extend it for functional disorders patient also, which are closely mimicking neurogenic bladder. So I will be briefly discussing the basic physiology of lower urinary tract function and its neuro association, and then we'll be taking you through to the assessment of filling and voiding phase, the final interpretation before concluding. So as we all know, the filling phase is marked by inhibited detrusor function and overactive and active function of bladder neck as well as external sphincter, and it is augmented by excitatory bladder to urethra reflexes and inhibitory urethra to bladder reflexes. The voiding function includes switch, which leads to relaxation of sphincters and contraction of detrusor to completion of voiding, and it is also augmented by a switched inhibitory bladder to urethra and urethra to bladder secondary reflexes. Now, on the right side, there is a brain and spine diagram. There are 4 dots on it. The first dot denotes pons, because pontine maturation center is the seat of this paradoxical switch. And the second point is a T6 spinal level, which corresponds to approximately T8, T9 of vertebral level, which marks the start of sympathetic outflow. So a lesion which is above this point will actually lead to decentralization of sympathetic outflow also. Then this third point is the S1 or above. So any lesion which is above this point will lead to decentralization of parasympathetic pathway only. Then there is the fourth dot, which actually denotes the damage of S234 or even the peripheral damage to S234. So all these things have their implication. And we should also remember that there is reflexive voiding till 4 or 5 years of age with less inhibition and voiding typically in high pressure as such. So what is the implication of these 4 dots? Any lesion which is above this will lead to detrusor overactivity, but a coordinated sphincter. Any lesion above the second point will lead to detrusor overactivity as well as hyperactive sphincters, both bladder neck and external sphincter. Any lesion which is above the third point will lead to detrusor overactivity as well as coordinated internal but non-coordinated external sphincter. Any lesion which damages the S234, whether it is within the spine or outside the spine, it will markedly reduce the detrusor activity, and it will also cause sphincters to be partially tight, partially relaxed, and non-responsive. Now, the interpretation of urodynamics is divided into 2 phases, filling phase and voiding phase. In the filling, I'm including the stress phase also when done. So we will look at sensations, we will look at detrusor overactivity, the compliance, which is the rubberiness of bladder, leak points like detrusor leak point or overactive leak point or stress leak point. Then if the EMGs are done, how to interpret them. Then if urethral pressure, I will not discuss urethral pressure because that will lengthen the presentation and it's very rarely done, although it's a very useful investigation in my experience. Then in children, we should most of the time combine the urodynamics with either a video if we have available, or even an MCAG done separately also is sufficient. So the common neurogenic conditions like spinal dysraphism, sacral agenesis, or spinal tumor, spinal injury, cerebral palsy are various reasons for having to perform urodynamics, or the non-neurogenic causes which give rise to very problematic to the child are posterior urethral valve after primary treatment of valves and dysfunctional voiding, which can even present like Inman syndrome, which is no less than neurogenic bladder for upper tract damage. So during filling, we should mention or notice at what rate the filling was there. Now, it should be 5 to 10% of functional bladder capacity. How do we know? Whether by, if the patient is on CIC or self-voiding, we'll know by bladder diary. or we can have an estimate like for an infant, it's 7 ml per kg, or for more than 1 year old, it's age plus 1 into 30 ml. Position of the patient should be marked. Size of the catheter, the smaller the better. We should note that what size of catheter was used. The smallest cystometric catheter, dual lumen, is about 6 French, or alternatively, equally effectively, we can use 2 infant feeding tubes. So let's say if you're using a 5 French feeding tube, which are 2, it is not equal to 10 French obstruction, because you have to consider the area, not one dimension. So actually, it is about 7 French obstruction. So 2 feeding tubes is equal to using 7 French 1 tube, and so on. In cystometry, sensations in adults particularly are important. The ICS recommends filling first sensation, first desire to void, strong desire to void, and urgency for leak or pain should be marked separately. However, in children, particularly neurogenic bladder, it may not be practicable, or the children are not toilet trained, like typically less than 5 years of age. It is not practicable. Now, more important issues are bladder overactivity. So detuser overactivity, if one is noted, then we should mention other things. Like in the first graph, you see there is this third graph, the green graph is a P detuser. There is a low amplitude repeated overactivity. We should know at which volume it started. And the second graph, you see, it was a high amplitude overactivity, which was associated with leakage. So whether leak was present, it should be noted. Now coming to compliance, which is possibly the most important parameter to look into when we are doing any neurogenic bladder evaluation, because this is the single most factor which will decide the risk for upper tracts. So in the first graph, you see normal compliance means the volume is increasing without much increase in the detuser pressure. In the second graph, you see clearly a poor compliance. The green graph is P detuser. It continues to increase progressively as the filling is going on. And when this happens, we should stop the flow for at least 1 minute and see whether the pressure detuser was reduced, because a poor compliance has 2 components. One component is active, which is by the tonus of detuser, and it will respond to stopping the flow. The other part is because of the fixed loss of compliance, because of the collagen deposition. So this differentiation is important. Like in this example, you see that on stopping the flow, the P detuser reduced from 55 to 43, but still it remained very high. And if the patient already is on anticholinergics or beta-3 blockers, there is very less hope for any conservative management. So he or she will possibly need a more aggressive management. On the contrary, this one, you see that the P detuser had increased to 36, but on stopping the flow for 2 minutes, it progressively reduced to 16, so more than 50% drop. And this is the patient who will possibly respond to more conservative management like Botox, or if the anticholinergics have not been given, those ones. A normal compliance is more than 20 ml per centimeter of water, and high risk compliance for upper tract is less than 10 ml per centimeter of water. Then if the EMG is done, we should look at guarding reflex. Now, guarding reflex is any of the 3 upper graphs, a progressively increasing EMG activity on progressive filling. And it happens because of these active secondary bladder to urethra and urethra to bladder reflexes. Now, if in a EMG, which is representative, means the EMG electrodes are properly placed by the side of anus as close to that as possible, properly fixed, and the baby is not straining or crying, then the second, third, the last 3 graphs do mention that there is something wrong with the guarding reflex. So there can be a neurogenic or even functional component that you cannot say. Then there comes leak point pressure. So these leak point pressures, mainly it is detuser leak point pressure, which is a passive urine leak during filling, where there is no active detuser contraction, or there is no straining or coughing or sneezing. Now, higher that leakage, or if the leak does not happen beyond 40 centimeter of water, it's a high risk situation for upper tract damage. And in this particular case, we are correlating it with these MCU films. Now, it's the same patient's situation after augmentation cystoplasty. You see the compliance has markedly improved. The PDET max has reduced to less than 20. and the baby is still leaking at 20 centimeter water, which is a low risk situation for this patient's upper tracts. And this will be managed accordingly. If not by CIC, then one may have to do an outlet increasing procedure. Then abdominal leak point pressures are also important, in which the provocation method in the first spike shows cuff, the second spike shows Valsalva. So that should be noted, and this will give some idea about how weak is the outlet. Now, coming to the voiding phase. So in patients in whom we expect who are self-voiding, active voiding phase, in this we look at two components. So it's essentially finding a relation between pressure and flow. So we should know how much potential a particular detrusor have. So suppose, is this detrusor contracting strong enough so that the patient is able to pass urine to completion with or without an obstruction? So it is in adults, it has been defined as, particularly males, detrusor contractility index with the formula given on the screen. The other parameter which this pressure flow study tells you is how much is the obstruction, means how much is the resistance to flow, this which is given as bladder outlet obstruction index. These two graphs, the top one ICS and the bottom one Schaefer nomogram, they are of great importance when analyzing the adult outflow. However, in children, and it is given as a normal pressure normal flow, a high pressure low flow, or a low pressure low flow situation, and they are very well defined. However, in children, they are not validated. Although in our experience, we find that these are potentially valid, but there is no study to prove that. So that is why when you have an apparent high pressure or normal pressure situation, you should corroborate it with a separately done MCUG, or you should do a video urodynamics. So now let us try to decipher one by one. So an apparent normal pressure, normal flow graph. You see in the filling phase, you have this detrusor overactivity, and each of this activity, you see the increase in EMG. So this EMG is actually, we are teaching this patient urge inhibition. So this patient had urgency, and we asked the patient to do urge inhibition and see the urgency is improving. So that means during urodynamics, you can actually do a kind of biofeedback on EMG. And you see that once the patient was giving command to volitional voiding, the patient did generate good detrusor pressure and voided with very good flow. In this, as per adult parameters, it was unobstructed and good detrusor. In this high pressure, low flow situation, you see a good detrusor relaxation during the filling phase, and you see an obvious high pressure and low flow situation with relaxation of sphincter. So this looks like a person who is neurologically intact and has some sort of an obstruction, unless this was a young baby less than 5 years of age who are expected to void with the high pressure low flow. In this case, AG number was high, obviously, and detrusor was contractility was good, more than 100, and his MCU showed a bladder neck obstruction, but there is also a sphincter obstruction. So this is the limitation we have to interpret in the light of clinical data. This is another situation in which you find there is a poor compliance filling phase with the phasic detrusor contractions, irregular, persistent, and towards the end, you see there are high amplitude overactivity, and which is coupled with increased EMG activity. And one of these overactivity became very high amplitude, and there was a equivalent increase in the detrusor contraction as well as the EMG, and the patient voided a very small amount. In this case, there was a obstructed AG number with weak detrusor. So an MCU correlate showed Ferntree appearance of bladder, grade 5 reflux, open bladder neck, and non-opening sphincter, external sphincter. So this is a case of detrusor overactivity with DESD. Now, this is another case of high pressure low flow. This patient has severe overactivity. During filling phase, we can see the first two spikes, and then there was a third spike in which the patient attempted to pass urine, and there was an obvious obstruction because high pressure low flow is seen. But in the same patient, when we ask the patient, we gave volitional command to void, patient developed some contraction, and then there were 2 episodes of overactivity. But this time they were lower amplitude and the flow was higher, and it showed non-obstructed. So now which one you go for it, whether this patient is obstructed or not, very difficult to say. So this case turned out to be a dysfunctional voider secondary to idiopathic overactivity long-standing. So you see that MCU shows in the first part, you see the bladder neck is not opening well. And in the second part, the bladder neck opened well, but the sphincter still is not opening well. So this patient was managed with medications and pelvic floor relaxation. There's another situation you see, this looks like obviously high pressure, then low flow and increased EMG activity. But if you look at the perspective, so this was actually high amplitude overactivity. We taught this patient urge inhibition, and the patient still kept on leaking, but ultimately was able to control. And on volitional command to void, the patient voided with fairly low pressure and excellent flow, as corroborated with the MCU also. So pressure flow relations are valid only for voluntarily initiated maturation. If the patient is having overactivity, and unless you give a voiding command well in advance, it is not a valid outflow relation and measurement. Now, what's the difference in all of these 4 graphs? So if you have an intact pontine maturation center and all the nerves peripherally, then you will, in presence of bladder neck obstruction, you will get high detrusor pressure because the detrusor is having to function against resistance. Whereas if the PMC is excluded from the bladder, so what you will find, you will have a external sphincter non-relaxation, and that will give rise to high pressures, not the internal sphincter, as long as the lesion is below T6 level, and that will be corroborated only by MCUG. Beware of autonomic dysreflexia, which is a dangerous condition in patients who have high spinal lesions, particularly above T6 spinal level. Now coming to a low pressure, low flow situation. So this first graph you see the good compliance, where fairly low detrusor pressure during filling, and the patient upon command of voiding, the patient voided with low pressure, low flow situation. The AG number was in equivocal range, and bladder contractility index was almost normal but somewhat low. And you can see that EMG is relaxing during the voiding. This is another image of the same situation, where you see that the EMG is relaxing, there is low pressure, and the flow is also low. So in this case, we should do an MCUG to find out whether there is any secondary obstruction or not, because by looking at the graph, you cannot say. Now, this is a second situation in which, again, the P detrusor is low only during filling, so good compliance, no overactivity, and the patient has voided with low pressure, low flow. But now you see the difference. The difference is in the voiding in the detrusor pattern. You see it's more plateau pattern compared to the previous one. It is more of a bell shape, flattened bell shape pattern. Now, what is the explanation? You see this, it was corroborated with the MCUG, and we found that external sphincter was not relaxing properly in this case. I will come to that explanation. Now, this is the third situation in which there is a poor compliance. This is a girl with dysfunctional voiding, and there was no neurological correlate found. But this, she had presented with hydrouretronephrosis, elevated creatinine. Urodynamics had revealed a poor bladder compliance. She had already been taught pelvic floor relaxation, because of which she was able to empty her bladder completely. You can see that the end fill period is up to 36 centimeter water, which is fairly high. But when she started voiding, there was a relaxation of pelvic floor with no straining, and the pressure fell down, and there was no obstruction. Now here one question arises. What is the detrusor pressure? Is it 34? But actually she did not raise the detrusor pressure beyond the end fill period. So though actually the detrusor pressure is almost 0, but we don't know. So we have to correlate with MCU. In this case, the MCU revealed that thickened trabeculated bladder, but a nicely open outlet. So this case was of a poor compliance, but there was no problem with the outlet. Now, what's the difference between the these 3 scenarios? In a diffuser underactivity, you will find that diffuser is not responding properly to even obstructed outflow. So you cannot know whether there is an obstruction or not, but you know that there is diffuser uh, underactivity. Now, in these cases, you will find a bell-shaped diffuser pattern. Now, this is our original research, and first time it has been reported by us from PGI Chandigarh, and there is another publication in the pipeline. Now, in the other situation where the external sphincter is not relaxing properly, so what is doing it is inhibiting the diffuser secondarily, and that is also giving rise to diffuser underactivity, which is denoted by a flattened diffuser contraction curve. Now, coming to areflexic or atonic diffuser. Now, that's a situation you should always remember that the diagnosis of areflexic or atonic diffuser is based on clinical scenario, because during voiding phase, if the patient is unable to initiate micturition reflex, or if the patient is voiding by habit by straining, you cannot say areflexic atonic. You have to corroborate with clinical finding. Like in this situation, you see that there is poor bladder compliance and the patient is not able to void by relaxation. Now, this is a case of sacral meningomyelocele, open meningomyelocele. So we don't expect this patient to be able to void voluntarily. So in this case, you can say this is atonic diffuser with poor diffuser compliance. Now coming to second scenario. In this, you see there is a flat line of period infilling. Here, the voiding command was given, and the patient is able to generate small amount of diffuser contraction, but the patient is then voiding, trying to void by straining. Now, in this case, micturition reflex was generated, which was very, very weak, but then it gave way to his habit of straining to void. Now, this is an elderly diabetic I put up directly because purposefully to just give a differentiation that this is a case of severe diffuser underactivity. We cannot say whether it's obstructed or not, but there is severe diffuser underactivity, and we should be careful about it. Now, this is a third scenario. Now, in this case, you see the diffuser compliance looks normal. However, there is a small rhythmic contraction kind of thing of diffuser. The patient is voiding by straining, but able to empty the bladder completely. Now, this is a patient with augmentation cystoplasty in neurogenic bladder, and this patient, this rhythmic diffuser contractions are actually the small bowel rhythmic contractions. So in this case, we know that this will not be able to void. So it will not be able to initiate a micturition reflex. So this straining will denote areflexic diffuser. And this is that patient. On straining, the patient is voiding. There is no active diffuser contraction in this. So finally, urodynamics is the backbone of management of neurogenic bladder and even functional voiding dysfunctions where there is high risk for upper tract damage. Urodynamics questions must be formulated before getting the study done. A proper quality control, a proper performance, which includes making the child comfortable with the environment. If the small baby who will cry during the study, we should place the catheter up front, I mean beforehand, and then do the study later on, so that the child is adjusted to the catheter. Sometimes small amount of sedative can be used, but not anesthetic. And a proper interpretation is essential that way. There are artifacts and limitations which should be taken into account. And lastly, we cannot label a bladder neurogenic bladder. There is no diagnosis neurogenic bladder. Neurogenic bladder is basically bladder bowel dysfunction because of neurogenic condition. So neurogenic can only be labeled with proper clinical correlation. On urodynamics, you can only propose findings, not label as a neurogenic or non-neurogenic. So thank you very much for patient listening. And a time has come to judicially use antibiotics. In our practice, we don't use antibiotics systemically. We always get the culture done. If there is infection, we treat it beforehand, before 2 days. During the study, in such cases, we use amikacin in the filling fluid, and we discharge them without any antibiotics. Thank you very much for patient listening.